Thank you all for joining this educational medical webinar provided by Handi-Craft Company's Medical Division. Today I am honored to present Catherine Shaker. Catherine is a pediatric speech-language pathologist with Florida Hospital for Children's in Orlando, Florida, who has advanced training with clinical instrumental assessment and treatment of swallowing and its disorders. We all know that. We all recognize Catherine's name. With over 39 years of experience, Ms. Shaker is nationally recognized as an expert in swallowing and feeding across a continuum of pediatric settings, including neonates, medically fragile infants, and children through school age. She's an ASHA board certified specialist in swallowing and swallowing disorders, has been an integral part of large level 3 neonatal intensive care units for over 30 years, and is well known for her work on cue-based feeding approaches in the NICU. She's published several manuscripts on NICU intervention and co-authored the Early Feeding Skills Assessment Tool for NICU Infants with Suzanne Thoyer of Chapel Hill. Catherine provides video fluoroscopic swallow studies for infants and children and is certified in neurodevelopmental treatment, trained in pediatric FEES and vital stim as well as SOS. Ms. Shaker lectures both nationally and internationally to physicians, nurses, therapists, and families. You can follow her on her website, www.shakerforswallowingandfeeding.com. Today, Catherine Shaker will be presenting Supporting Parents Feeding Preemies. It's not just about intake. And welcome, Catherine, and everyone for this very informative presentation.
It's a pleasure to be here with all of you this afternoon. I wanted to begin by letting you know that I have no financial disclosures and non-financial disclosures relevant to this presentation today. I'd like to begin by acknowledging Dr. Brown's to begin with for its support of medical education for all NICU caregivers and especially for families. I'd like also to give appreciation to my many NICU nursing and neonatology colleagues who over the last 30 years of practice since I've been in the NICU have partnered with me to support neuroprotective infant-guided feedings. I'd also like to express appreciation for the many therapists who have been inspired by my work, who I continue to learn from, and whose practice with families has been informed. And how could we forget, of course, the many families of NICU infants over the years, for me, whose gratitude for my teaching has been just amazing. Our objectives, as you see here, you probably have seen in your post from Dr. Brown's webinars. I'd like to talk about the unique attributes of the NICU setting and what may create a volume-driven focus on feeding, which unfortunately is often inadvertently passed on to parents. We'll also talk about the role of relationship-based care and parent-infant communication in fostering infant-guided feeding, and look at the use of what is called guided participation to support parents in gaining both confidence and competence in feeding their preterm infant. I like this slide of this man and this little boy. It reflects for me the need to always be asking questions and be thoughtful from moment to moment throughout the feeding, and certainly always looking for the evidence base to guide our practice. The scope of our passion in the NICU, of course, the parents should be and are at the center of our work, and we may see sick newborns and very critically ill preterm infants who now, of course, are at a point where feeding is the next frontier. If only it were this simple to learn about feeding in the NICU. Well, in fact, feeding preemies may be considered by some a fairly routine task rather than a critical component of NICU care. Often the technology of the nursery, attention to numbers rather than infant behaviors, and non-individualized ways of providing care can unfortunately affect the culture of feeding in an NICU. The importance of the feeding relationship and the infant's positive learning can easily get lost in the numbers, unfortunately, when the parent's focus is primarily on emptying the bottle to get the infant home. And indeed, the developmental nature of learning to feed may unfortunately be overshadowed by well-intentioned professional caregivers who, for example, may describe feeding as a light bulb phenomenon. That is, the infant all of a sudden figures it out and therefore knows how to feed, versus what we know is reality, that learning to feed is a developmental process that requires carefully titrated support for the preterm infant. So when we provide parents with skills to co-regulate their infant, who guides them during feeding, we then support parent-infant attachment, reduce stress, and improve intake. What sometimes can happen is that with good intentions to get infants to eat, some caregivers may do whatever is necessary to get the volume in, and this may include feeding past the infant stop signs. What happens then is this can result in both physiologic stress and negative learning behaviors for the preemie, who may then struggle to breathe when swallowing and breathing compete. And indeed, what that can lead to, and I've seen it, is infants who develop refusal behaviors in order to signal, please stop feeding me. And then we have this pathway to feeding aversions. It's sad, but the pressure to get the babies out the door is very often passed on to the parents. I just met with a mom before I started this webinar who told me how wonderful her baby does with breastfeeding, but that she hasn't been doing it because she knows they're looking at measuring numbers and she wants to get her home. How sad that is for both mom and baby. So what happens is that pressure comes from modeling by well-intentioned caregivers who maybe push the baby beyond his limits. It comes by asking or telling parents to continue the feeding even when the baby may be disengaging. And it also comes from a focus so much on talking about volume, how much the baby took, and that how fast the baby took it become so much of the conversations, unfortunately. It is important to recognize that because the infant has been born premature, during the period when they're learning to feed in the NICU, we understand that they're in the process of developing motor and sensory neural pathways. Stressful experiences during feeding may alter those pathways in the brain and indeed guide the infant away from feeding and adversely affect the ability to feed both in the NICU and long after discharge. Indeed, there are multiple papers that have come out in the last 5 years reporting very poor feeding outcomes for former preemies, many of them suggesting, is there something about the NICU experience that promotes stress in learning to feed and therefore results in maladaptive feeding behaviors through these motor and sensory pathways, through stress, that then creates infants who are overwhelmed and have feeding problems that endure. So that I remember to let you know, an important website that fits right in with this concept of negative experience is feedingmatters.org. There you'll find information about the importance of positive feeding, not only in the NICU, but beyond. So the concern is that the increased exposure to stress in the NICU actually has been associated with alterations in brain structure when babies reach term age. So we're learning, as research helps us, to know that every experience in the NICU matters. And indeed, I truly believe that every feeding experience matters for our infants. Feeding, of course, can be very stressful for our preterm infants, and they show this stress by their communication. They often indicate their ability to cope with the stress of feeding or not cope with it through changes in their heart rate and respiratory rates, how hard they work to breathe, their oxygen saturations, and indeed how well they coordinate suck, swallow, breathe. All caregivers must be alert for changes in these parameters to avoid serious consequences of instability, which can occur with feeding, including apnea, a slow heart rate, or what we call bradycardia, rapid breathing, color change, or loss of state and postural control. These occasions of decompensation can lead to poor control of the larynx, the pharynx, the esophagus, and of course can be the pathway to airway compromise. When the infant feeds, these are parameters that we have to be paying attention to. So many new things, of course, for moms, that when your focus has been the healthy newborn all your life, you suddenly have an infant in front of you who is preterm and is learning to feed, that we know it can be very challenging to understand really what is happening. An example of that is a mother of a baby I'll call Jaden. We received an order that said, speech to consult, mother refuses to feed infant. And when I saw it, my heart just felt so sad. And I said, I really have to take this consult to see how we can help this mom. As it turned out, she was handed her preterm infant to feed. I think it was the second feeding the baby had ever had, and the nurse had to step away to answer a monitor. Meanwhile, mom fed the baby like a newborn. She let the baby suck, and what happened, without recognizing the cues that the baby was losing physiologic stability from sucking in a prolonged fashion, the baby choked, braided, changed color. I wasn't there, but mom remembered that event for a long time. When I came to see her, she said, I won't feed her. I caused her to get into trouble. So we know that learning the language of prematurity, the communication of a preterm infant during feeding, is something that one doesn't just pick up. And we need to support our parents in feeling they understand their infant's communication. We know that feeding can be stressful for preterm infants, and indeed, feeding safely and achieving adequate intake for growth requires integrating multiple systems for the preterm infant. When we think of feeding from a dynamic systems model, physiologic stability is the foundation for safe feeding. And we know clearly that our infants, when they do communicate to us about their physiologic stability, often their communication may not be understood by the caregiver, may be inadvertently disregarded, or may not even be noticed. And what can happen then is that we have a situation where instead of opportunities for communication, listening to the baby, observing his communication, reflecting on the meaning of the infant's behaviors, supporting his efforts, respecting his limits, what happens then is the communication isn't recognized, and babies often are rescued when they have a major event of decompensation that actually the baby was telling us long before it actually happened that I need help, please listen to me and support my safety. What happens is, instead of minimizing stress and increasing safety and stamina, babies then will have events of stress that can create, again, changes in the brain, and learning that feeding is not something they want to readily engage in. The signs of disengagement from our infant, as you see on the screen here, some of them include engagement would be actively rooting. The baby is alert, he's content, he's showing physiologic stability. He's saying to his mom and dad, I want to continue, I'm okay. And even 15-year-old parents can learn quite readily how to understand that look and that behavior of engagement from the infant. Signs of disengagement, however, where the infant is trying to say, I am done, I need to rest, please stop, include pushing the nipple out, pulling off the nipple, no active rooting or sucking, purposeful use of a weak sucking pattern, and indeed shutting down with inability to respond to gentle re-alerting. When we see that the cues are not recognized, the focus then can become on getting the food in the infant, and well-intentioned strategies create stress for the infant. These well-intentioned strategies, as I like to think of them, are often volume-driven, meaning that one might, for example, increase the flow rate to empty the bottle, prod the infant, which takes away the infant's active sensory motor control over feeding, and delivers an anticipated flow, of course, into the baby's mouth and pharynx. It may be putting the head back to use gravity to empty the bottle, and of course that increases the infant's risk for bolus misdirection and airway compromise. People may often, in a volume-driven culture, unswaddle the baby to, quote, keep him awake, which actually takes away critical postural support for the swallowing mechanism. The infant may be expected to continue feeding despite sometimes subtle signs of physiologic instability, or behaviors that suggest swallowing and breathing are starting to uncouple. For example, drooling, formula out of the front of the mouth, gulping, the onset of nasal flaring and blanching, taking only small, infrequent breaths, and then changes often in the eye gaze patterns. Feeding, of course, for parents can be very stressful in the NICU. They may experience the loss of their own homeostasis due to the stress of having a preterm infant. So it's not uncommon for us to see parental anxiety, depression, and the sense of a loss of autonomy. So what can happen is that worries about the infant's survival, long-term prognosis, are often compounded by guilt and failure about giving birth too soon. Of course, shouldn't be the way a parent might feel, but we hear often that is common. So the dissonance between the parent's expectations and the reality of parenting a preemie are often especially stressful for the parents. Theorists have proposed that when the parent of any infant is supported in understanding the infant's behaviors and responding promptly and appropriately, they establish trust. And that is what helps the parent-infant relationship thrive. Infant feeding certainly offers the earliest opportunity to support this connection between parent and infant. So often what can happen is the parents, I hear from them, can become stressed by well-intentioned caregivers that provide information which lacks consistency. I had one father say one time, you know what, I'm out of here. Every person tells me how to feed my baby differently. You're telling me one thing, this person is telling me another. I have had it. I'm leaving now. So we know that as we all are not on the same page, or some people perhaps have a sense that their approach might be better, how important it is as a team that we work together so that there is continuity of approach to feeding, and therefore not only is the parents learning supported, but also the infants. Very often, well-intentioned caregivers may take over the feeding from the parent. Oh, mommy, he's not getting enough. I'll do the feeding. And then I see parents sometimes watching while a caregiver, perhaps a nurse, feeds the baby and empties the bottle, and what happened to the relationship between the parent and the infant, separate from how the baby may have tolerated that end to the feeding. We also know that many parents watch the clock. Have you noticed? I've seen a mom say to her dad, honey, we only have 2.5 minutes left. You better get going. And I'm always trying to explain to them, you know, mommy, why the clock is there, it's not there to guide feeding. They said you may hear, understandably, from the nurses that about 30 minutes is a good time frame for feeding, but do you know why that is? And often moms will look at me and say, well, it's the rule, right? And I often explain to them, no, actually it's based on research that as the baby feeds past about 25 to 30 minutes, nursing research suggests that they reach a point where they start to burn calories. Like when you work out, mom, you know, if you get on the treadmill for 5 minutes and jump off and take your shower, you probably didn't reach the point where you burn calories. But with our babies, at about 25 or 30 minutes, when they're working that long, we know that what starts to happen is they burn calories. I find that informing parents and giving them understanding empowers them to make good decisions for their baby. So in the NICU, we have basically two kinds of care, according to the research: task-oriented care, which is getting things done, checking it off the list, you've got to complete the task. But is this what feeding is about? If it is your internal working model of what feeding is about, you would believe and model that emptying the bottle is the goal, no matter what it takes, no matter what the infant may think about it. It's a noble cause, certainly, because we know things need to get done. However, if we look on the flip side, relationship-based care, this is the real current focus in all NICU writing and training. Relationship care, meaning that caregivers rely on the infant's communication, their cues, to guide the timing, intensity, and duration of every caregiving interaction. And for me, of course, most importantly, every feeding interaction for the infant, because we know that the ability to feed well is closely related to the sensitive response to the infant's physiology and that trust behavior that we want to build. The preterm infant's experience of feeding is strongly influenced by NICU caregivers. If we support the infant knowing that there will be variability in his performance, it's expected. He's learning a new skill. This variability is normal early on, so it isn't as if a light bulb's going to go off and in some moment he's going to get it. Often, if we think that the baby has established his skill and someone says to the mom, oh, the light bulb went off, he's doing it now. When that variability shows up, and it will, we have moms who are crying in the parking lot sitting in their cars because they thought the baby got it, he's good to go. And really what this is if parents understand that this is a process for the infant, they know that they see him learning and they're there to support him. It's a very different paradigm. When we think about a little trouble advancing, I think we froze up here a little. Technical difficulties are never fun, are they? Let me just bring this up. There we go. Okay. So it's important that caregivers, all of us, support the confidence and the competence of the parent in building a trust relationship between themselves and the baby. I just met with a mom before I came to do the webinar who was telling me some approaches she was using during feeding with the baby. I don't really think they're probably the best support for the infant, but what I wanted to do was to let her know in my conversation I valued her understanding of her baby, her key learnings in her relationship surrounding feeding with her infant, because of course she knows her baby more than I do. It's important that we value the parent's perspective, knowing that as we work with them, perhaps we can change some of their impressions if it's necessary for the baby's safety, but to always value them. My colleague Suzanne Thorey, who's a PhD nurse at Chapel Hill, a great friend of mine and a phenomenal colleague, tells a story of a mom that she was seeing for a research study they were doing. She came in and they were going to do some videotaping of the feedings, and she said to mom, she introduced herself, talked about their research project, and she said, "Mommy, tell me what you've learned about feeding from your baby." Do you know what happened next? The mom started to cry, and she said, "You're the first person in 140 days who has ever asked me, what do I think about how my baby feeds? What have I learned, and what can I tell you?" She said, "Everyone comes to tell me what I should do, how to feed her, but no one seems to think what I think matters." So how important it is that we remember that. One of the earliest opportunities for parents to build that relationship is through feeding. We know that as we do support our parents, there are things that we can do in general in the NICU, aren't there? First of all, can we all keep working at realigning the NICU feeding culture by moving away from volume-driven to what I like to call infant-guided feeding? The baby matters. This is quite an undertaking, and it doesn't happen overnight. And the unit that I'm in, we're still in the process of working that direction. As you have new physicians, new practitioners, new nurses come and go, we sometimes have to realign the culture and recognize everybody wants the best. We're all trying to do our best. But if we can move away from task-oriented care to relationship-based care, we do that one baby at a time, one relationship at a time with the caregivers with whom we are blessed to be able to work as members of the NICU team. We want to help everyone embrace the goal that every feeding experience matters, because we know that we're looking down the road for long-term feeding success for every baby that we have in the NICU. We want to, at every opportunity, model an infant-guided feeding approach in all feeding interactions, consistent quality feeding experiences. And can we help to change the focus during all conversations in the nursery, from rounds, where often the focus may be on what percent was PO? Can we help to bring in quality? At handoff communication from nursing, can the focus be, instead of the volume the baby took, which is a good part of the data, extend that to how the baby looked, his physiologic stability, what interventions seem to help? And when parents are updated, they call in and say, how did the feeding go? Can they hear, you know, Mommy, today he stayed awake for his whole feeding. I barely had to wake him up. If I just slowed him down, he could catch his breath. Sometimes he likes to go fast. That's a good thing, but sometimes it can be too much. So we slow him down. He was awake after the feeding. I think he's learning. Very different than saying, I got 45 mLs in him. You see, it makes it all about the caregiver then, and not about the baby and the relationship, the feeding relationship that we all hopefully are trying to build. So we want to feed our preterms in ways that I like to say support neuroprotection, wire the brain not from stress to maladaptive pathways, but wire the brain to those pathways that support lifelong joy in eating. So what else can we do? Respect the infant's communication. That means rest the infant for maybe 10-15 seconds at the first sign of infant disengagement. Terminate the feeding when the infant says he is done, for whatever reason, or is unable to continue, in lieu of making the infant continue and doing whatever is necessary so that the infant takes his volumes. It's a great pressure, I think, on nurses, because there are occasions when I've heard neonatologists say, you know, was the nurse lazy? She didn't get him to take it all. I even hesitate to say that in a webinar, but every time I hear that, my heart just aches, because I have so many nursing colleagues around me who are such wonderful infant-guided feeders. You see, when we have volume-driven expectations that the infant needs to take the volume, it can come from the very top down, and it can cause the wrong way of thinking that creates disrespect, if you will, as opposed to saying, isn't it great that Judy let him be done when he was, because we're all about protecting the baby's brain for the future. We need to let the infant's communication guide us from moment to moment. That means watching that baby, because literally in a heartbeat, the communication through either how the baby looks, how his eyes change, how his breathing changes, how his swallowing changes, those changes need to be responded to contingently as soon as they happen. Ideally, avoid those stress signs, but at least respond to them so that we don't wait until we have to rescue the infant. So ideally, we want to look at intake within the context of the infant's developmental strivings, and really as a byproduct of a quality feeding interaction. Intake is not the goal of the feeding. We want to develop bedside feeding plans for each infant, even infants who aren't involved with a therapist supporting their feeding. Why is that? Because it should act as a guide to the infant's typical communication cues during feeding and what is currently working the best to support the infant's emerging competence and safety. If we do that, we know that what will happen is it will hopefully reduce variation. I see this as a key issue because often feeding the preterm infant can change from feeding to feeding depending upon your caregiver, whether it's a change in the nipple, go to faster flow, and even faster flow, change the position. He's fed sitting straight up. He's fed sitting more supine. Hopefully at some point he's fed on his side. As these components of the feeding approach change, it interferes with learning. I often say to parents, you know, if your child was in first grade and things are going well, you come in and talk to the principal and she says, you know, Mr. Smith, we're starting something new because starting next week, your child's going to have a different first grade teacher every day. Isn't that great? Well, Of course, the parents laugh, and they do need to laugh here and there. And I say, you know, the point is that when there would be a new teacher, learning would change and start over every day, wouldn't it? And you would never like that. So the important thing is having the parents involved once we've helped them understand the baby's communication facilitates continuity in learning so that learning doesn't start over every feeding. And unfortunately, sometimes there's caregiver preference. There may be, unfortunately, disrespect for therapists' suggestions or recommendations for feeding, and really what needs to happen is that we all need to have a conversation. One neonatologist told me long ago, when I thought the baby should advance to twice the day feeding, this was back in the 80s, and he thought the baby shouldn't advance. Isn't that a nice difference that would happen? He said, you know, Catherine, it's all right if we disagree, as long as we respect each other. And that has stayed with me a long time, and I think that's what we always need to bring in as we try to pull that team on the same page on behalf of the baby and his family. Maternal feeding behaviors, of course, are important for the healthy newborn. Look at this big old newborn, so cute, just love him. The mother's ability to focus on the infant's cues from the first day of life forms the basis for her sensitive and responsive management of his life indeed, but certainly his feeding. The mommy structures the feeding, so hunger satisfied, feeding is pleasurable. It's quite an experience in a relationship. For mothers of preterm infants in an NICU, they also, beyond this, which they're trying to build, need to learn maternal adaptive behavior, I like to call it, meaning that during the feeding, they need to observe the infant's needs, recognize how those needs for support may change quickly at any moment, monitor for change, problem solve when they respond to the infant's communication, what is the result, and then monitor that in an ongoing way to keep their baby safe. This relationship and these adaptive behaviors that we teach parents are critical towards not only protecting the airway, but of course neuroprotection. I like to think about the dance of attachment with a healthy newborn. You know, for the newborn, this is what creates a blueprint for the infant's well-being, his brain development, nervous system regulation, ability to manage stress, his sense of security and trust in his parents. Parents regulate the environment for their infant, and during stressful experiences, parents always look for ways to minimize the stress by using their infant's communication to guide them. And indeed, for our babies who are preemies, it's this learning to dance with your infant that we want to be supporting. Positive, safe feeding, but it requires not only information, what am I looking for, but how to look carefully and problem solve through a feeding. I like to liken a good feeding between a caregiver and a preterm infant as learning to dance. I often say to mommies, remember, Mom, when you first were learning to slow dance with someone, maybe it was someone who didn't dance very well, and maybe he stepped on your toes, and I always say, not you, Daddy, and they always laugh. But that guy stepped on your toes or kind of pushed you around the dance floor because he wasn't a good dancer. And all you could think was, man, I hope this music ends soon. I've got to get out of this dance. But when you dance with someone who is in sync with you and you are just moving so smoothly, you think, I want this dance to go on forever. And I say, you know what we want, Mommy, is for your baby to say, I want this feeding to go on forever because it feels so good. This feels great. So we help parents learn to listen, watch, respond during feeding, understand the cues of disengagement versus engagement, understand breathing and swallowing behavior that can help guide them, and then understand key infant-guided interventions. I remember being asked to see a mom who it said, mother refuses to use slow flow nipple was the order. What an interesting thing. I came up to see her. She was probably in her early 40s. Very nice mom. I said, Mom, tell me about feeding and your baby. She says, well, I don't want to use a self-flow nipple. I think it's going to hold her back. I said, I appreciate what you're finding out. Let's start the feeding. I'm going to start with the medium flow nipple. As I started swaddle the baby, talked about swaddling. As I started to feed her, I said to Mom, I noticed, Mom, the milk is splashing out of her mouth. And I think that it might be coming too fast. I'm going to slow her down. Look, her eyebrows are going up. I think she's getting too much. There, now I'm going to let her catch her breath. As I started to show her the stress she was having, I said to Mom, do you mind if we just look at the self-flow nipple? I'd like to see what she tells us. By that point, the mom knew I had her baby's interest at heart, and she said, oh, of course. As I showed her using the self-flow nipple and co-regulated pacing, I said, I think she likes this, Mom. Do you think this looks better? Did you notice how she seems breathing easier? And all of a sudden, the mom sat back in the chair. I thought for a minute, yikes, she's going to tell me to get out of the room maybe, but she started to cry. And she said, this is the first time I ever realized Savannah's been trying to talk to me, to tell me something during feeding. I had no idea. I just kept making her suck. So, you know, we have those moments like this where you say, wow, in this day of my work, that made a big difference. And from that point on, that baby began to thrive and Mom supported her. So when we think about co-regulated feeding, we're looking to build that parent-infant attachment through communication during feeding. When we think of co-regulated feeding, that means that you view the infant as a partner in feeding. He's an active participant who guides you. And the caregiver, especially the parent, is a partner with the infant who understands the infant's behavior, knows how to respond effectively, so feeding is less stressful and more successful. And as well, the caregiver should value the perspective of the infant. I always say to parents when we're done feeding, Mommy, if he could tell you, if he could talk, and if you said to him, how was this feeding for you? What do you think he would say? And sometimes mommies say, I think he'd say he likes it. Some say, I don't know what he'd say. And I always say, you know what he'd say, Mommy? You really understand me, don't you? You let me catch my breath. You know when I'm ready to go again. I liked this feeding. You see, we're building their relationship. So we provide opportunities for breathing and rest periods, decrease the flow of milk by adjusting the sucking burst length by using a slow flow nipple, responding to loss of milk at the lips with rest periods, pauses in sucking to allow the infant to reorganize swallowing and coordinating swallowing with breathing. Decreasing demands at early signs of disengagement from the infant so that he understands and can trust you, and helping the infant pace his energy expenditure by co-regulated pacing. That means slowing him down based on his cues, not in an arbitrary way every 3 to 5 sucks or every 4 sucks, but looking at the baby from moment to moment. So I'd like to teach you a little bit about supporting parental confidence and competence in feeding, and I like to divide it into 3 phases. The first one is where the parents observe infant-guided feeding of the preterm infant. So typically this may involve a therapist who's been following the baby and is supporting progress from feeding readiness to very early small PO trials. The goal would be for the caregiver to use anticipatory guidance, meaning that you help the parents understand what we're looking for, watching for, and how to prophylactically help the baby be safe. We'll explain more about that in a minute. It's a time for parents to learn about the infant's communication and behaviors during feeding as you describe them while you feed the infant. Interpret the meaning of the behaviors, how important that is, how often it is that I see a nurse perhaps feeding while the parents are observing and nothing's being said. What an opportunity for learning that has been missed. We want to interpret that preterm infant's communication for the parents with the goal that they can then problem solve potential reasons why the baby's behaviors are changing or his breathing is changing, and then intervene in ways that they can problem solve and avoid having to rescue the infant. We allow parents with us feeding to explore interventions that might help their baby. So this is a period in my mind of the parent learning. I'm often asked, what about the first bottle feeding? I'm of the sense that first bottle feeding is done by parents are not the best. And I want to explain why. It isn't because I don't value the parents in that relationship. It is so important when a baby has an order to begin PO feeding, and if they've already breastfed or even if they haven't, if it's going to be by a bottle, I arrange whenever it's possible to have the parents here. And what I say to them is, Mommy, I know this is an important event for you to be a part of. The reason I'm not having you feed the baby right now is I don't even know really how to keep him safe. He's just learning. He shouldn't be out yet. I don't know his communication that might tell me he's getting into trouble. Can we learn along together while I interpret for you what I'm seeing? And my goal is going to be to meet with you each day so that you can learn his communication, so we get you involved in feeding him, because there's no one better to feed him. What I don't want to happen, Mom, is for him to get into trouble. He could even do that for me, for you to ever think it's something you did or didn't do, because that would never happen. We're all learning together from your baby. How important that is. And I know that's not always agreed with, and I respect that from other people, but I've never had a parent say, forget it, I'm going to feed them, because they sense you want the best for their baby, which is indeed what they want. So we begin this process early on when the first bottle feeding is initiated, feeding the infant while the parents observe and we teach. The caregiver interprets the cues. And so an example of thinking along with a parent, as I like to call it, I learned that from Suzanne Thorey, begins, for example, by saying, let's see what Selena tells us during feeding. Notice how her mouth didn't open, Mom, when I gently stroked her lips with a nipple. I wonder if she might be telling us she needs more time for breathing. Do you think so? Or I wonder if she's got a burp. Let's see what happens if we just give her time to catch her breath. Then if she doesn't root, we'll see if she has a burp. Maybe that's why she's choosing not to open her mouth. You see, we're teaching the mom to take the perspective of the infant. So another example of anticipatory guidance might be, let's watch while David is sucking to see if he gives us any signs he's running out of air and needs to catch his breath. There, Mom, did you see how Michael started bobbing his head and throwing his nostrils? I think it might mean he needs help to stop sucking. He sure loves to suck. Sometimes he can get stuck in sucking and can't stop without us helping. David needs us to help him take a series of deep breaths. Now watch as I gently break the seal on the nipple. I'm going to put the nipple right here, Mommy, on the corner of his lips so he knows it's there. It didn't go away. Look what he did. He swallowed. Look at those breaths, 5, 6, 7. That must feel good. I see his head's not bobbing anymore. I think he feels good. Do you think he likes this? So we're trying then to have the parents take the infant's perspective. As parents learn to assess their infant, I'm going to teach them about these interventions, which we've mentioned before. We don't have time in this webinar to talk in detail about the evidence base for these interventions, but if you go to my website, which Sandy mentioned, the publications that I've produced are on there. There's great detail about the evidence behind these interventions that I find in my practice work so well towards safe infant-guided feeding. In phase 2, the parents are going to feed while I support them to guide them. And so in this case, we use what is called from the nursing literature, guided participation. So you see the parents participate, but we act as their guide along with the infant. We coach them. So in this situation, we're going to be reinforcing the parent's interpretation of the infant's communication, their use of contingent interventions and their impact, and we want to reflect the infant's perspective back to the parent, because we're trying to again teach them to listen to their baby as they go along. So what happens is, as the parents progress from observing and learning along with us or with the nurse to feeding their infant with guidance, that builds competence and it builds confidence in the parents' minds. So for example, this might say, Mommy, I noticed that you gave Ryan a brief break from sucking. That's just what he needed. How did you know? And Mom will usually say, well, I saw him start to bob his head. I'll say, that's exactly it. You could really see that. Another example might be, I see you stop feeding briefly to re-alert Jose. Good thinking. How did you know when he was ready to start sucking again? Yes, Mom, you're right. He started rooting on his hands. Good thinking. He let you know, didn't he? Another example might be, I see you stop the feeding, Mom. How did you know Emily was done? That's right. She does look asleep. You can tell her arms are starting to move away from her face, and she didn't really re-alert. I think she's telling us that she's done. How nice of you to respect that. Emily does know how to suck, and if she's not sucking, there must be a reason. I think she's just too tired. Good thinking, Mom. You're listening to Emily. I think she knows you understand. That must feel really good. So as we build this trusting relationship between parent and infant, this is the beginning of the relationship for the future, many years down the road. And then, of course, parents feed the baby independently. What a great time. We're there to help, and we allow them to take the lead, and we're there in case they have a question. I like always then to reinforce their skill. Look at how great they were at understanding the baby's variability from feeding to feeding, how well they're problem solving, verbalizing that they're doing a good job, and the infant liking what is going on. So important, because we know that in the NICU, it's not uncommon for preterm birth to jeopardize parenting. And that reciprocity that we can support through feeding is so critical as an underpinning for growth, development, and parenting, so that we know that how the parents experience feeding becomes so important, and it should be everyone's goal from the first day of life, certainly to support the systems that allow the infant to feed safely and successfully in an infant-guided neuroprotective way. And of course, it takes all of us. I happen to love dogs, and I love this old picture. It's so cute. It takes all of us fully engaged and intentional, committed to the mantra that every feeding experience matters to make the difference that we need to for our babies. And this is, of course, where we're headed, isn't it? This is what we want for outcomes after the NICU specific to feeding, and everyone has to be engaged to get us there. So we hope today that some of the information has been helpful. Certainly it's always a process as we all try to grow and improve in our skills. I learn something every day in the NICU. That's the best blessing of being in this team that I'm on. I wanted just to close with letting you know, as I've been on the ASHA website and one of the bloggers for ASHA, and I've received emails personally from several moms who are speech pathologists telling me about their feeding experiences in the NICU, and as I read them, I sometimes cry at my computer because of what they went through. And one of them said, I wished I had known the information you shared with us at that time. How important it is when parents share their journey with us through the NICU, especially through feeding and their struggles with feeding. I feel it truly is a gift to be a part of supporting infants and families in the neonatal intensive care unit. We know that with that gift, though, comes many challenges and opportunities for all of us in the nursery through supporting infant-guided feeding and using the infant's communication. We as therapists can clearly build and reinforce reciprocity between the infant and his parents. Supporting parents in learning to feed their preterm when the focus isn't solely on intake can completely change the parent-infant relationship. I've seen it happen so many times. Parents often say, she's learning to trust me. I know my baby, I can do this. There's no greater feeling for me at the end of a long, challenging day in the NICU than to know that I've made a difference, even in a small way, for infants and their families, not only to get them home, but to support that parent-infant relationship going far forward. And the building blocks for that relationship have started with feeding. Even if you're listening to this and you don't work in an NICU, by being aware as a mommy of a former preemie, as a friend of someone who has a preterm infant, to support moms and dads who have preemies in understanding the baby is their guide, to always trust his communication and learn to build that relationship with him. I hope today, for those of us working in the NICU, that I've provided some resources, both research and theory, to help us all open dialogue, facilitate new perspectives, and most of all, help all caregivers remember that the infant's communication matters in the NICU. Sandy, I'm available for questions. I know we don't have a lot of time. Even if we have a couple, I'd be happy to take them.
Well, thank you, Catherine. That was very informative and very insightful. As you know, we always appreciate your insight. Unfortunately, we don't have time. We probably have about a minute here. We do have some very good questions that I would like to send you, and then if you could answer them, then we would forward them on to the everyone who was listening to the webinar. We truly appreciate your time and your expertise, as you know. I want to thank everyone for joining us. Our next presentation will be on Thursday, June 23rd at 1 o'clock Eastern. You'll get emails about it. The topic will be Managing Infant Oral Feeding Challenges in the NAS Epidemic, Strategies for Individualized and Unit-Specific Interventions. This will be presented by Mary Stanford from Teachers College at Columbia University, Program of Speech Language Pathology, Department of Biobehavioral Sciences. Thank you everyone again, and Catherine, especially you, and everyone have a great day.
Thanks, Cindy.